Hello, my name's Dr. Don Buford. I'm an orthopedic surgeon based in Dallas, Texas, and I'm the moderator of tonight's AAOS webinar titled Using Platelet Rich Plasma for Knee Osteoarthritis, Clinical Evidence and Practical Tips. We have an expert faculty. We're going to talk a lot about the current evidence-based uses of platelet rich plasma for knee osteoarthritis. We have a question and answer session at the end, so bring all of your clinical questions and we will happily discuss them and see what kind of consensus we can reach. These are my disclosures and they're available on the AAOS website. This is a link to the handout. You can find it on the internet at buford.info/AAOS 2025. So why do we need biologic options for knee osteoarthritis? It's important to understand the natural history of this diagnosis. The lifetime risk of getting a knee replacement in the United States is 7%. 50% of the adults diagnosed at some point with knee osteoarthritis get a knee replacement in the United States. Another reason why we might need a treatment option like platelet-rich plasma, which is a non-surgical, minimally invasive treatment for knee osteoarthritis, is we eliminate the risk of surgical revision. If somebody is my age, 55 to 59 years old, this paper showed that there's a 1 in 5 chance that I would need a revision knee replacement if I have a knee replacement today. That's pretty high. And most of the patients that come see us at Texas Orthobiologics are aware inherently of this risk, and they want to avoid surgery if there's other potentially successful treatment options. So what are the current FDA-compliant biologic injections? You can see them on this slide: bone marrow aspirate, bone marrow concentrate, adipose or microfat, and of course, platelet-rich plasma. What's not on this slide is Wharton's jelly, amniotic fluid, exosomes, peptides, other placental tissues. And so we're going to focus in this webinar on platelet-rich plasma. So what have we learned about PRP dosing for knee OA in the last 4 years? And you're going to see this formula multiple times in this 10-minute presentation. Platelet dose is simply platelet volume times platelet concentration. Here's what we've learned. Just this year already, there's been another level 1 meta-analysis published. This meta-analysis looked at 18 trials. The total patients in this meta-analysis was close to 2,000. And the summary was quite simply that platelet concentration is directly related to improved outcomes. Higher platelet concentrations gave statistically significant better outcomes. Lower platelet concentrations, specifically under 1,000 in the platelet evaluation, did not achieve clinically perceivable benefits versus normal saline. So although this isn't specifically on dose, remember dose is volume times concentration. This meta-analysis looked at concentration and found that this one component of dose is directly related to outcomes. And now we're going to go through some of the dosing studies as well. So let's look at some of the recent level 1 trials looking at low-dose PRP. Low-dose PRP is defined here as less than 3.5 billion platelets, which is an arbitrary designation, but you'll see that the outcomes do tend to vary above and below that benchmark 3.5 billion dose. In 2021, this level 1 Restore trial was published based out of Australia. The PRP kit that they used was the Regenlab's PRP kit, but the important thing here is that they documented the dose. So whatever kit you use, if your dose is what's been studied in this trial, you can expect similar findings. In this example, the authors drew 20 cc's of blood. They injected 5 cc's of leukocyte-poor PRP. The average platelet count was 325 in the PRP. Remember that meta-analysis earlier. If you're below 1,000, the outcomes are really no better than saline. And that's exactly what this level 1 Restore trial found also. The platelet dose, which you get by multiplying that platelet count of 325 by the 5 cc's, was 1.6 billion platelets per injection. In this protocol, they even did 3 injections. And even with 3 injections, that was not enough. The outcomes did not support the use of this low-dose PRP in the management of knee OA because the results are no better than salt water. So that's a really important, well done, in my opinion, well quantified level 1 trial showing that low-dose PRP was not effective for knee OA. But that's not the only study that's shown that. In 2022, there was another level 1 trial, this time using Arthrex ACP, looking at the same question. The study design was a little bit different. In this study, there were 112 patients enrolled. There are three randomized groups: placebo, one PRP injection and two placebo injections, or three PRP injections weekly. Now, for those of you that aren't familiar with the Arthrex ACP, it's a 20 cc blood draw, at least in this protocol, and they made 5 cc's of PRP, pretty similar to the RegenLab protocol. The estimated max platelet dose was below 3 billion platelets, and I say that because I'm giving them the benefit of the doubt. They injected 5 cc's, but they didn't give us a platelet count. So if we assume an average mid-range human platelet count, then that's going to give us a expected dose below 3 billion platelets. What they found with 1 year of follow-up was no clinical differences between the groups. There was no difference if you got 3 of these low-dose PRP injections, or if you got just salt water, or if you got 1 PRP and 2 salt water injections. So keep that in mind. There's now 2 well-done level 1 trials showing that low-dose PRP is not effective for knee OA. So is that where we stop? Do we just set this aside and go back to just doing steroid shots? I don't think so. I think there's an answer here, and this is what the rest of this presentation is going to show you. Let's look now at the level 1 trials for high-dose PRP. These will be doses in these trials above 3.5 billion platelets. So I want to talk about the Bonsall trial, which was published in 2021. This was a level 1 trial with 150 patients. This is a high-dose PRP trial, looking at the same question: does PRP help with symptoms and function for knee OA? Notice the difference in blood draw volume, 60 cc's. So we're 3 times higher in terms of blood draw volume compared to that Restore and the PEAK trial. This is a manual 2-spin protocol. It's a single injection protocol, just 1 injection, not 3. And he documented very clearly exactly what the dose was. He injected 8 cc's of PRP. The platelet count was 1,250. And when you multiply those two together, the answer is 10 billion platelet dose. The comparator in this trial was Monovisc HA. And what he found at 1 year was that the patients that had the high-dose PRP injection, again, a single injection, still had outcomes on WOMAC, IKDC, and VAS scores that were above the minimum clinically important difference. And so and with Dr. Bonsall's study, he stopped and evaluated the patients at 1 year. So it's quite possible these patients did better and for longer than 1 year. But certainly at 1 year, he documented this outcome. That's not the only high-dose PRP trial that shows benefit for knee OA. Here's another one. This is by Dr. Chu, and this was published in 2022. This is a little bit different, so let's work through it. This is a level 1 trial, very large N of over 600 patients. 50 cc blood draw, again, 2.5 times more than 20 cc's in the PEAK and Restore trials that showed no benefit. 2-spin protocol. Here's one of the differences between this study and Dr. Bonsall's. This is 3 injections weekly. He also does a very nice job quantifying the dose. 5 cc's of PRP. The platelet count was 832. That makes the per injection dose 4.2 billion platelets. And again, he gave this 3 times. So the total dose, if you added up all 3 injections, would be over 12 billion, but the per injection dose was still above that 3.5 billion cutoff, which is somewhat arbitrary. In his study, he documented that the PRP-treated patients still had outcomes that were statistically significant at 2 years. So he studied these patients longer than Dr. Bonsall did and documented that, again, with a per injection dose of 4.2 billion or a total dose of 12 billion, that patients had statistically significant outcomes, statistically significant in terms of pain and functional improvement at 2 years. Quite different from the low-dose PRP level 1 trials that show no benefit. So what are the tips to get high-dose PRP? Number 1, always draw at least 60 cc's of blood. You can see that from the studies that have successful outcomes. And I say that because I assume the worst in my clinical practice. I assume that every person walking in the door has a platelet count at the low end of normal, 150. If I assume low normal and I draw 60 cc's, that means in that syringe, I've got 9 billion platelets. If my patient's doing better than 150 on their platelet count, then we're golden, we're even better. But I assume the lowest normal platelet count. If I start with 9 billion platelets, then I want to use a kit that has a consistent, and that's highlighted and underlined for a reason, because some kits are not consistent, but I want a kit that's going to have a consistent platelet recovery percentage of at least 50%, because if you do the math, if I start with 9 billion, my kit recovers at least 50% in my PRP, I'm going to have 4.5 billion platelets in that injection. That's above Dr. Chu's study that had 4.2 billion platelets. Now, if I'm consistently using an injection at 4.5 billion, I might want to match Dr. Chu's protocol and give that injection 3 times. I do like the idea of treating these patients with a single injection, which means I'm often trying to get my doses significantly higher than 4.5 billion platelets. How do you do that? Well, the answers should be relatively obvious at this point. If you want higher doses, you've got 2 main clinical choices. You can draw more blood, or you can use a better kit that has a platelet recovery percentage higher in the 60, 70, 80, or even 90% range. And those kits are out there, and we have data, as do many others, identifying which kits those are. So this is probably the best clinical tip I can give you in terms of getting to high dose PRP, especially if you don't have a hematology analyzer in your office. So in summary, I present this level 1 PRP evidence along with my personal 5+ years of registry data in data biologics. I present that to the patient. It is an open, often lengthy discussion, 30 minutes, 45 minutes, whatever it takes. And it includes cost, and it includes FDA regulatory status. So we are clear on all of the issues that I think are relevant to make a decision. We discuss the patient's specific clinical status and their candidacy. Is this patient similar to the patients that were in these studies? Can I expect a similar outcome? What grade of arthritis do they have, and does that affect the outcome? Do they have significant structural changes that might affect the outcome? Do they have alignment issues? All of these things go into this conversation. So to the best of my ability, I give the patients an understanding of what they can expect. Patients can then decide if their expected PRP outcome is something they want to pursue. And I'm here to tell you that most of my patients, once they have this discussion, opt for something that is done in the office, that is done in less than 30 minutes, that is done with ultrasound guidance, that is minimally invasive, and that doesn't burn any future surgical bridges if that were still necessary down the road. Thank you very much. Appreciate being given the opportunity to moderate this webinar. I hope we get a chance to do more on other topics like rotator cuff tendinopathy. But for now, I'm going to stop, and we'll open it up for a Q&A session. And no question is too large or too small. Thank you very much.